Hello everyone, I am myself Dr. 𝗑𝐲𝐫𝐞. I am the general medicine educator. So in this particular section, I'll be doing the quick revision of the entire endocrinology. So the first topic in this particular section will be related to the Addison's disease. So what exactly is the Addison's? As we have discussed in the main theory, Addison's is a disorder which is characterized by the adenocortical insufficiency, right? And this Addison's, it is of two forms. One is, or the adenocortical insufficiency is in two forms. One is the primary adenocortical insufficiency and then the secondary adenocortical insufficiency. So primary adenocortical insufficiency is that where the pathology is in the adrenal gland, whereas in secondary adenocortical insufficiency, the pathology is within the pituitary gland or within the hypothalamus. Now, what exactly will be the difference in the hormonal levels between primary and secondary adenocortical insufficiency? In primary, you have decrease in steroids. Then you also have decrease in mineralocorticoids. There is also decrease in the weak sex hormones. That is what you will observe in case of the primary adenocortical insufficiency. Whereas in secondary adenocortical insufficiency, it is only just decrease in steroids and as well as decrease in the weak sex hormones, whereas the aldosterone levels, it will remain normal, right? The aldosterone levels, it will remain normal in secondary adenocortical insufficiency. And another very important point is about the ACTH level. In primary adenocortical insufficiency, the ACTH and MSH, both of them are increased, whereas in secondary adenocortical insufficiency, the ACTH is reduced and along with that the melanocyte stimulating hormone levels are also reduced. So thereby in primary, these patients, they will have the hyperpigmented skin, right? Whereas in case of the secondary adenocortical insufficiency, they will have the hypopigmented skin, and this hypopigmented skin in case of secondary adenocortical insufficiency, this is what is called as the alabaster skin. Right, so this is what is called as the alabaster skin. So these are the differences between the primary and as well as the secondary adenocortical insufficiency. Now quickly you need to be aware of what are the etiologies that will be causing the Addison's. And please remember, we use the term Addison's only for primary adenocortical insufficiency. So in the etiology, you need to know the most common cause of Addison's in India will be tuberculosis, whereas most common cause of Addison's in the Western countries will be autoimmune adrenalitis, and the other important bacteria that will be causing the Addison's apart from tuberculosis will be Neisseria meningitidis, which is nothing but meningococci, and this Neisseria meningitidis will cause the acute adrenal insufficiency, which is called as Waterhouse-Friderichsen syndrome. And this Neisseria meningitidis causing Waterhouse-Friderichsen syndrome, which is nothing but meningococci, it is mainly observed in children and as well as the newborn, right? And these patients with Waterhouse-Friderichsen syndrome, they'll have acute adrenal insufficiency causing vascular collapse, hypotension, coma and death if you don't treat them immediately. So the drug of choice in these patients is you need to give IV hydrocortisone. So basically what this Neisseria meningitidis will do, this Neisseria meningitidis will cause the adrenal hemorrhage, right? So this will cause the adrenal hemorrhage, and because of which these patients will have the abdominal pain, and the antibiotic that you need to give is intravenous ceftriaxone is what you need to give, right? Then what are the other etiologies? The fungal infections which will be causing the Addison's will be histoplasmosis. Then we have the viral infections causing the Addison's, that is the cytomegalovirus, and we have infiltrative disorders causing Addison's, and that includes the excessive accumulation of iron within the adrenal gland, that is the hemochromatosis, right? Hemochromatosis. And the other important etiology will be amyloidosis, where there is abnormal accumulation of abnormal protein within the adrenal gland. And the other important etiology is sarcoidosis, where you have accumulation of the non-caseating granuloma within the adrenal gland. So these are the etiologies that will be causing the Addison's, which is nothing but primary adenocortical insufficiency. And if you take the clinical features in case of the Addisons, the clinical features in case of the Addisons, they're mainly due to the steroid deficiency. The clinical features are due to the aldosterone deficiency, and the clinical features are due to the weak sex hormone deficiency, right? Now, so if you take the clinical features due to steroid deficiency, that includes the hypoglycemia, and these patients due to steroid deficiency will also cause the hypotension. So it is both hypotension and postural hypotension can be there in these individuals, and these patients will have fatigue. They will also have the weight loss, right? And these patients, they will have loss of energy, and these patients due to steroid deficiency, they will also have fever, and these patients will have eosinophilia, and these individuals will also have lymphocytosis and anemia. So these are the clinical features or the features that you will have because of the steroid deficiency, right? And due to the aldosterone deficiency, they will have hyponatremia, and they will have all the clinical features of hyponatremia. That includes the altered sensorium, that includes seizures, coma, and death. And these patients, because there is hyponatremia, they will be having salt craving, and they will have hyperkalemia, right? So they will have hyperkalemia, and there is increase in the H+ ion level, resulting in the metabolic acidosis. Because aldosterone is not there, the H+ ion does not get excreted out. And these patients will also have postural hypotension because the water absorption is not there. So when do you call the postural hypotension? That is the fall in systolic blood pressure, it should be more than 20 millimeters of mercury, and fall in diastolic blood pressure, it should be more than 10 millimeters of mercury. And so from supine position, after standing for 3 minutes, you need to check the blood pressure, right? If the fall in systolic is more than 20 and fall in diastolic is more than 10, then we use this word called the postural hypotension, right? Now, due to weak sex hormone deficiency, right? So due to weak sex hormone deficiency, the features are mainly observed in females. So what is that features that you will have in females is they'll have decreased energy, right? And they will be having loss of secondary sexual characteristic features, right? That is loss of axillary and pubic hair. And these patients, they will have dry and itchy skin, right? Dry and itchy skin. So these are the features that you will have due to weak sex hormone deficiency, right? Then after having discussed about this, you need to be aware of the other important features. In primary, we have discussed that there will be hyperpigmented skin, and this hyperpigmentation is first observed in the sole and as well as the palm creases. This is the place where the hyperpigmentation is observed, and followed by that the hyperpigmentation is also observed in the axillary area as well. Then how is that you will do workup for these patients? So in the diagnosis of the Addisons, the investigation of choice is the 𝐒𝐮𝐬𝐫𝐞 test. The 𝐒𝐮𝐬𝐫𝐞 test, the another name for this is also called as the ACTH stimulation test, right? So this is also called the ACTH stimulation test, right? Or this we also call it as the 𝗠𝐴𝐷𝐼𝐶 test, right? So this we also call it as the 𝗠𝐴𝐷𝐼𝐶 test. So these are the various names for this 𝐒𝐮𝐬𝐫𝐞 test. Now you need to be aware that in 𝐒𝐮𝐬𝐫𝐞 test, you will be able to make out only primary adrenocortical insufficiency. You will not be able to diagnose secondary. Only primary adrenocortical insufficiency can be made out by your 𝐒𝐮𝐬𝐫𝐞 test or ACTH stimulation test or the 𝗠𝐴𝐷𝐼𝐶 test. Then how is that you will be able to differentiate primary from the secondary adrenocortical insufficiency? That you will be able to make out by the aldosterone levels. So if you take the aldosterone levels in primary, they are decreased, whereas in secondary adrenocortical insufficiency, the aldosterone levels, it remains normal, right? So that is how you will differentiate primary from secondary adrenocortical insufficiency. Now coming to the treatment in case of the Addisons, In primary adrenocortical insufficiency, the drug of choice is hydrocortisone. Now, why is that we are giving hydrocortisone in the primary? The reason is that in case of primary, it is both the aldosterone deficiency and as well as the steroid deficiency. So you need to give a drug which is having both aldosterone and steroid activity, which is nothing but the hydrocortisone. Whereas in secondary adrenocortical insufficiency, the drug of choice will be dexamethasone. Because in secondary adrenocortical insufficiency, what did we discuss? That in secondary, only steroid deficiency will be there and aldosterone levels will remain normal. So you need to give a drug which has maximum steroid activity, and that particular drug which is having maximum steroid activity is dexamethasone. So these are some of the very important points related to the Addison's or adrenocortical insufficiency. The next topic let me discuss in quick review manner is the Cushing syndrome. What exactly is the Cushing's? It is a clinical condition which is characterized by excessive production of the steroids. So now you need to be very much aware of, first and foremost, what is the most common cause of the Cushing's. Most common cause of the Cushing syndrome is the supplementation of the iatrogenic steroids. And what is the most common cause of, right, supplementation of iatrogenic steroids? Then what is the most common cause of the non-iatrogenic Cushing's? Right, the most common cause of non-iatrogenic Cushing's. Most common cause of non-iatrogenic Cushing's will be the pituitary adenoma. Right, so that includes the pituitary adenoma, right? Then what is the most common cause of the ACTH dependent type of Cushing's? The most common cause of the ACTH dependent type of Cushing's is again the pituitary adenoma, and the steroid production can be even from the ectopic sources. What is the most common ectopic source for the Cushing's? The most common ectopic source for the Cushing's, that includes the small cell carcinoma of the lung, right? This small cell carcinoma, which is also called as the oat cell carcinoma, right? Which is also called the oat cell carcinoma. Actually, there are many ectopic sources for the development of the Cushing's. That includes small cell carcinoma of the lung, then followed by that the pancreatic and as well as the bronchial carcinoid, then followed by that the pheochromocytoma. So these are all the ectopic sources for the Cushing's. But out of this, the most common cause will be the small cell carcinoma of the lung or the oat cell carcinoma of the lung, right? Then what is the most common cause for the ACTH independent type of Cushing's? The most common cause for the ACTH independent type of the Cushing's, right? What is the most common cause of the ACTH independent type of the Cushing's? That includes the adrenal adenoma. So these are all the important etiologies causing the Cushing's. Now you need to be aware of the clinical features in Cushing's. What is the earliest clinical manifestation in the Cushing's? The earliest clinical manifestations in the Cushing's will be the weight gain, right? Weight gain is the earliest clinical manifestation, and followed by that, due to redistribution of the fat in these patients, they will have a moon-shaped face, right? And not only that, because of redistribution of the fat, there will be also buffalo hump, right? And the next important feature because of redistribution of the fat is development of the central obesity. And this central obesity, it is a very important risk factor for insulin resistance, causing the type 2 diabetes mellitus, right? And you have some important skin manifestations that includes the skin atrophy. Then these patients, they will have the easy bruisability, right? Then these patients, they will have the very important feature, that is the purple striae. And in case of the ACTH dependent type of Cushing's, these patients will have the hyperpigmented skin, right? And these patients will also have the development of immunocompromised state, causing increased fungal infection, right? Causing increased fungal infection. Okay, so these are all the skin manifestations that you will have in patients with the Cushing's. And related to metabolism, carbohydrate metabolism, these patients, they will have hyperglycemia, right? And lipid metabolism, these patients, they'll have dyslipidemia and lipolysis, causing increase in the free fatty acids. right? And the protein metabolism is that there is excessive proteolysis causing the proximal muscle myopathy, right? Causing the proximal muscle myopathy. So these will be the abnormal metabolisms that you will have in patients with the Cushing's. And cardiovascular system manifestations is that these patients will have hypertension, and CNS manifestations is that these patients, they will have psychosis and the emotional instability. So this will be the central nervous system manifestations that you will have in patients with the Cushing's, right? And followed by that, in patients with the ectopic ACTH, please remember there is excessive activation of INAC causing edema, and not only edema, there will be also hypokalemic metabolic alkalosis, right? Hypokalemic metabolic alkalosis. So these will be the features in case of ectopic ACTH being producing steroids, where there is excessive activation of ENaC, right? And these patients with Cushing's, they are also at increased risk of thromboembolic events, right? They are also at increased risk of thromboembolic events, okay? Then followed by this, you need to be aware of the workup. So what is the first line investigation in these patients is, first line investigation is 24-hour urinary cortisol levels. So 24-hour urinary cortisol levels, they are elevated. That is the first line investigation. Once the 24-hour urinary cortisol levels are elevated, then you need to check the ACTH levels, right? Then you need to check the ACTH levels. Now, if you find that the ACTH levels are reduced, then you need to suspect the individual is having the adrenal gland disorder, right? So if the ACTH levels is reduced, either it might be, it is ACTH independent type of Cushing's, right? If suppose, if the ACTH levels are increased, then you need to suspect it as the ACTH dependent type of the Cushing's, right? Now, if you are suspecting ACTH independent, then what is that you need to do is, you need to do CT or MRI of the abdomen, right? CT or MRI of the abdomen. Whereas in case of the ACTH dependent type of Cushing's, like the investigation of choice will be MRI of the pituitary, that is mainly to look for the pituitary adenoma, because the most common cause of Cushing's is most common cause for ACTH dependent type of Cushing's is pituitary adenoma. Now, if suppose the pituitary adenoma, if you find that it is normal, because in 90% of patients, even though there is pituitary adenoma, the sensitivity is only 90%. In 10% of individuals where the tumor is very small, the MRI cannot detect even though there is presence of the pituitary adenoma. So that is the reason why what you need to do is, you need to do a high dose dexamethasone suppression test, right? High dose dexamethasone suppression test. Now with this high dose dexamethasone suppression test, if suppose if the ACTH levels are reduced, then you need to think of the pituitary adenoma. If the ACTH levels are still on the higher side, in spite of giving high dose dexamethasone, then you need to think of the ectopic ACTH producing the Cushing's. Either it might be small cell carcinoma, pancreatic and bronchial carcinoid, medullary carcinoma of thyroid, or even the pheochromocytoma, right? Now, if you are finding that the ACTH levels are reduced and it is pituitary adenoma, but MRI was normal, then in such case, what you need to do is, you need to check the petrosal venous sinus sampling, right? Then you need to check the petrosal venous sinus sampling for ACTH, right? So petrosal sinus sampling for the ACTH has to be tested here, right? Now, the very important, so that is about how you need to diagnose. Then after having discussed, you need to be aware of the very important part of the workup. If it is ectopic ACTH, where all it is coming from, either small cell carcinoma or pheochromocytoma, pancreatic and bronchial carcinoid, and then medullary carcinoma of thyroid. So if you are finding that it is ectopic ACTH, then you need to do CT or MRI of the abdomen and as well as thorax, right? As well as the thorax. right? So this is about how you need to work up a patient with the Cushing's. Now, after having discussed about the workup, then you need to know the treatment. So what exactly is the treatment of choice for Cushing's? So the treatment of choice for the Cushing's will be surgical excision of the tumor, right? Surgical excision of the tumor. Now, if there is any contraindication for surgical excision, then you need to give the medical management. And among the medical management, what is the drug of choice? Among the medical management, the drug of choice will be the ketoconazole. So ketoconazole, why is that we are giving ketoconazole? Because it is adrenal enzyme inhibitor and it prevent the steroid hormone synthesis, right? And the next important drug is, if there is ectopic ACTH, what is the most common cause for the ectopic ACTH causing Cushing's? That is small cell carcinoma. So if it is small cell carcinoma, then the drugs that you need to give is the irinotecan, right, plus cisplatin. So this is the drug that you need to give. And if there is bilateral adrenal adenoma or bilateral adrenal carcinoma, where you have done bilateral adrenal resection. So if once you have done bilateral adrenal resection, the individual will land up in the steroid deficiency. So once you have done a bilateral adrenal resection, then in this scenario, you need to give replacement steroids. And this particular replacement steroids, right? So this particular replacement steroids, that includes the hydrocortisone. So this is about the Cushing's in quick recap. After having discussed about the Addison's and as well as the Cushing's, let me do a quick revision on the Conn syndrome. So what exactly is your Conn syndrome? It is a disorder which is characterized by hyperaldosteronism, right? And where is this particular aldosterone being produced? This aldosterone, it is being produced from the zona glomerulosa of the adrenal cortex. And this aldosterone, where will be the site of action? That is over the distal tubules, that is over the collecting duct and as well as distal convoluted tubule. And the cells on which this aldosterone will act is the principal cells. And the channel on which this aldosterone will be acting is the ENaC channel, which is also called the epithelial sodium channel. And what will be the physiological action of the aldosterone? Aldosterone will cause sodium and water retention, potassium excretion and H+ion excretion. And the very important function of the aldosterone is to maintain the blood pressure. Now, what is the stimulus for the aldosterone synthesis? Please remember, for the aldosterone synthesis from zona glomerulosa, it is not the ACTH which is coming from anterior pituitary will stimulate the aldosterone production. The aldosterone synthesis, it is completely dependent on the RAS mechanism, that is renin-angiotensin-aldosterone system. So if there is a hypotension, if there is decreased fluid volume, if there is decreased renal perfusion, that is the point when there is activation of the RAS. So once there is activation of RAS, there will be production of the aldosterone. And if this aldosterone is being produced in excess quantity, that will result in the hyperaldosteronism. So this hyperaldosteronism, it is of the two forms. So one we have, it is the primary hyperaldosteronism, then secondary hyperaldosteronism, right? So primary hyperaldosteronism is that where the pathology is within the adrenal gland, and most common cause of the Conn syndrome, that will be the adrenal adenoma. Whereas if the question is asked like what is the most common cause of the primary hyperaldosteronism, the most common cause of primary hyperaldosteronism will be bilateral adrenal hyperplasia. That will be the most common cause for the primary hyperaldosteronism, right? And the next important point is the secondary hyperaldosteronism. The most common cause of the secondary hyperaldosteronism is that it is the congestive heart failure, and the next important is the cirrhosis of liver, right? Next important is the cirrhosis of liver. Okay, so this is about the etiology causing the hyperaldosteronism. Now you need to be aware of what will be the clinical features in these patients with the Conn's. The clinical features in patients with the Conn's or hyperaldosteronism, they're mainly because of three reasons. Number one, due to increased sodium and the water retention, right? And the next important is, in patients with hyperaldosteronism, there is excessive potassium excretion resulting in the hypokalemia. And in patients with hyperaldosteronism, there is excessive H+ion excretion resulting in the metabolic alkalosis. So, because of increased sodium and water retention, these patients, they will develop or they will have diastolic hypertension. That's the first important point. And second important point is, because of a phenomena called as the aldosterone escape phenomena. So I have discussed in main videos about the concept of the aldosterone escape phenomena. So because of this aldosterone escape phenomena, these patients, they will not have edema, right? And they will have normal urine output. So they will not have any polyuria. Polyuria will not be there, right? So because once there is like hyperaldosteronism, there is increased sodium and water retention. So thereby we may suspect that they will be having increased sodium and water retention causing edema and decrease in the urine output. They will not have polyuria. They will not have decrease in urine output. They'll have normal urine output. And all these is mainly because of aldosterone escape phenomena. Which, what is that? I have discussed, it's a detailed concept. I have discussed that in my main videos, right? Now, because of the hypokalemia, the clinical features that these patients will have is, they will develop polyuria and as well as the polydipsia, right? And because of the hypokalemia, these patients, they are more prone for the arrhythmias. And what arrhythmias are very common? That is, the ventricular arrhythmias are very common, that is VT and as well as VF. And these patients will also develop a very severe form of the muscle weakness, right? And because of decrease in the H+ion levels, these patients will develop metabolic alkalosis, right? These patients will develop metabolic alkalosis. So these are the clinical features because of the various electrolyte abnormalities. Then how is that you will do the workup? So if you take the investigation of choice in patients with the Conns, what is the investigation of choice is, it is oral salt, right? So it is the oral salt solution test, right? So oral salt solution test, that is the investigation of choice, right? Then what is the screening test? The screening test is, you need to check the aldosterone renin ratio, right? So aldosterone renin ratio will be increased. So once the screening test is positive, then we do the confirmatory test, and that confirmatory test is by the oral salt solution test. And those individuals who are not able to consume this oral salt solution, in them you need to do the IV saline suppression test, right? Or alternative to this IV saline suppression test, we have another test that is called as the fludrocortisone suppression test. Okay, so this is the confirmatory test, and these patients, they will be having a transient hypernatremia, right? They will be having a transient hypernatremia, and they will have hypokalemia, because of which when you do an ECG will show you that there is presence of the U wave and the T wave is inverted. And when you do an ABG will show you that there is presence of metabolic alkalosis. So this is about, and next is you need to do the imaging, that is CT or MRI of the adrenal gland, which will show you the presence of the adrenal mass, if it is due to primary hyperaldosteronism, right? Then how is that you will be treating these patients with the Conn syndrome? So the treatment of the patients with the Conn syndrome, the treatment of choice is the surgical resection of the tumor, right? But the problem here is, if the patient is having bilateral tumors, right? If the patient is having bilateral tumors, so how is that you will be able to identify that there is presence of bilateral tumors? That is by doing bilateral adrenal venous sinus sampling, right? Bilateral adrenal venous sinus sampling. So by doing the bilateral adrenal venous sampling, like what is that you need to check for? You need to check for the aldosterone levels in both the adrenal veins. And if the aldosterone levels are increased more than normal, then we consider that the patient is having bilateral adrenal tumors. Now, when there is bilateral adrenal tumors, we don't do surgical resection. Why? Because there can be development of the steroid deficiency also when you are doing bilateral adrenal resection. Then in such case, what is that you need to do? You need to give the aldosterone antagonists, right? And what are the examples of the aldosterone antagonists? That includes the spironolactone. But the problem with the spironolactone is that it can cause very important adverse effect, that is painful or tender gynecomastia. So in such case, what is that you need to give? The alternative aldosterone antagonist, that includes the eplerenone, right? That includes the eplerenone. So that is about the treatment for Conn syndrome. And you need to know the very important differential diagnosis for the Conn syndrome. The important differential diagnosis for the Conn syndrome is the Liddle syndrome, right? So it is the Liddle syndrome. Now, what exactly is the Liddle syndrome? It is a genetic disorder where the patient will have an autosomal dominant type of inheritance. What exactly is the problem in the Liddles? The exact problem in the Liddles, there is gain of function of the epithelial sodium channels, right? There is gain of function of the epithelial sodium channels, right? So that will cause increased sodium and water retention. That will cause the hypokalemia, and that will cause the decrease in H+ ion, resulting in metabolic alkalosis. So these patients, they will develop hypertension. But you need to remember that in both Conn's and as well as Liddles, right? In both Conn's and as well as Liddles, what is the type of the hypertension that you will have? So it is low renin hypertension, okay? Low renin hypertension. Because in both of them, either you take in Conn's or you take in case of Liddles, there is increased renal perfusion. So thereby the renin levels will get reduced, but the blood pressure is increased because of the hyperaldosteronism. Then what is the drug of choice for Liddles? We don't give aldosterone antagonists here. We give epithelial sodium channel blockers. And the examples of these epithelial sodium channel blockers, that includes amiloride, and the another important molecule is the triamterene, right? The another important molecule is triamterene. So this is about the Liddle syndrome. So this completes the discussion of the Conns. So now let me do a quick revision of parathyroid disorders, in which we'll be doing a quick revision of hyperparathyroidism and as well as the hypoparathyroidism. So first you need to be aware in brief about the regulation of the calcium. So the hormones which will increase the levels of calcium in our body are the parathormone, and the other one is calcitriol, which is nothing but the vitamin D. So the next important hormone which will decrease the calcium level will be the calcitonin. So this calcitonin, it is the hormone which is being produced by the parafollicular cells of the thyroid gland, whereas you take the parathormone, it is being produced by chief cells of the parathyroid gland. Now, you need to be aware that parathormone will increase the calcium. How it will increase the calcium? Parathormone will cause increase the osteoclastic activity in the bone, causing bone resorption. So that will increase the calcium level, right? And parathormone will increase the calcium absorption from the tubules. So thereby there will be increase in the calcium levels. And parathormone will increase the vitamin D synthesis by increasing the activity of 1-alpha hydroxylase within the proximal convoluted tubule. That will result in the synthesis of vitamin D. And what this vitamin D will do? The vitamin D is the one which will increase the calcium absorption from the intestines, right? Now, after having discussed about the basic metabolism, now you need to be aware of what is called as the hyperparathyroidism. So hyperparathyroidism, what are the etiologies that will be causing hyperparathyroidism is, that includes the following. So hyperparathyroidism, it is caused by like the primary causes where the pathology is within the parathyroid gland itself. So that is the most common cause for hyperparathyroidism will be solitary parathyroid adenoma, right? Solitary parathyroid adenoma. And the next important etiology is the parathyroid carcinoma, and then parathyroid hyperplasia. Then what are the secondary causes for the hyperparathyroidism? The secondary causes for the hyperparathyroidism, it includes the chronic renal failure, it includes vitamin D deficiency, right? And it also includes some drugs. What are those drugs? The drugs which will reduce the calcium, right? The drugs which will reduce the calcium. What are those drugs which will reduce the calcium levels? That includes bisphosphonates, right? And the drugs which will increase the vitamin D metabolism and thereby decreasing the vitamin D levels, and that includes the phenytoin. Okay, then what are the other causes for the hyperparathyroidism? The other causes for hyperparathyroidism, that includes the adenocarcinoma of the kidney, right? And then squamous cell carcinoma of the lung, right? Squamous cell carcinoma of the lung. So these are the etiologies that will be causing the hyperparathyroidism, right? Now, apart from these etiologies, we also have the other important genetic disorders called Janssen disease, and the other one is familial hypocalciuric hypercalcemia. So in these conditions also you will have the hypercalcemia. And the clinical features, if you observe, that all depends upon the calcium levels. What is the normal calcium level? The normal calcium level is 9 to 11 milligrams percentage. That is the normal calcium levels, right? Now, if the calcium levels have been elevated 11 to 12 milligrams percentage, what will be the clinical features? And if the calcium levels have been elevated 13 to 15 milligrams percentage, what will be the clinical features? And if the calcium levels have been elevated more than 15 milligrams percentage, what will be the clinical features? If the calcium levels have been elevated 11 to 12 milligrams percentage, the calcium gets accumulated within the kidney in the form of renal calculi. These patients will have the loin pain, right? And if the calcium levels are increased in a state of 11 to 12, this calcium will stimulate the parietal cells of the stomach, causing the excessive release of the HCl, causing the development of the peptic ulcers. Thereby these patients will have the gastric pain or the peptic ulcer pain, right? And this calcium will go and deposit within the sphincters of the GAT. Thereby there is contraction of the sphincters of the GAT, causing constipation, right? Causing constipation, right? And this particular increase in calcium level will also cause pseudo hypertension, because the calcium will accumulate within the vessels, and the calcium which is accumulated within the vessels will cause the stiffness of the blood vessels, and thereby it appears that the blood pressure is increased, and that we call it as the pseudo hypertension, right? That we call it as pseudo hypertension. And if the calcium levels have been elevated around 13 to 15 milligrams percentage, then in such case, like, what will be the features? If the calcium levels have been elevated 13 to 15, it will cross the blood-brain barrier and calcium accumulates within the brain, resulting in the psychosis. And calcium will also accumulate within the basal ganglia, resulting in the secondary Parkinsonism, right? That this will result in the secondary Parkinsonism, right? And not only that, if the calcium levels have been elevated in around 13 to 15 milligrams percentage, the calcium will, this hypercalcemia will also cause the systolic arrest and finally death of the individual. Okay, when the calcium levels have been elevated more than 15, that will cause systolic arrest and death of the individual. So that is what is the clinical features due to hypercalcemia. And next is, you need to be aware of the bony abnormalities. So if you take the bony abnormalities in these patients, there is increased bone resorption resulting in the osteoporosis, right? And there is also, right, the pathological fractures because of the osteoporosis, right? There is also pathological fractures because of the osteoporosis, right? And there is accumulation of the fibrous tissue within the bone, resulting in the osteitis fibrosa cystica and the other fibrosa cystica. And the other important bony abnormalities, right? The other important bony abnormalities that you will have is the presence of the codfish spine, right? Or the development of the codfish spine. And the other important bony abnormality will be the development of the Rutger-Jersey spine, right? The development of the Rutger-Jersey spine, okay? And even within the tooth, there will be demineralization of the mandible, which will result in the loss of lamina dura, right? That will result in loss of lamina dura. And how is that you will work up these patients with the hyperparathyroidism is, so in the workup, you will find that there is hypercalcemia and you will notice that there is decrease in the phosphorus levels and the alkaline phosphatase levels, they are increased. But remember, this alkaline phosphatase levels in early stages, they remain normal. But as the time progresses, as the severity of the hyperparathyroidism increases, then the alkaline phosphatase levels are also elevated, right? Then you need to do a DEXA scan for assessment of the bone mineral density. And because of the hypercalcemia, what does the ECG show? The ECG will show you that there is presence of a short QT interval, right? There is presence of the short QT interval, right? And the next important is what exactly is the investigation of choice, or how is that you will be able to localize the parathyroid adenoma. You will be able to localize the parathyroid adenoma, that is by doing technetium-99m system EB scan, right? Technetium-99m system EB scan. So it is with the help of technetium-99m system EB scan, you will be able to make out the presence of the solitary parathyroid adenoma, right? After having discussed about the workup, then you need to know the treatment of the primary hyperparathyroidism. The treatment for primary hyperparathyroidism, the treatment of choice is the surgical resection of the tumor. Right, the treatment of choice is the surgical resection of the tumor. That is the treatment of choice, right? But if the individual is not able to undergo surgery, or if there is any contraindication, then you need to give medical management. So in the medical management, like what is the drug of choice in case of primary hyperparathyroidism? So that includes the bisphosphonates. Okay, because your parathormone is causing osteoporosis, it is increasing bone resorption, causing hypercalcemia. So you need to give bisphosphonates. Bisphosphonates are the one which will decrease the bone resorption, and these particular drugs include the ibandronate, right? Or the other important substance that we have is the alendronate or zoledronic acid can be given. But what will be the first line treatment for hypercalcemia? The first line treatment for the hypercalcemia is you need to give IV fluids plus the furosemide. So this will cause the flushing out of the calcium from our body. So, and this IV fluids, it includes the normal saline. So this is about the treatment of the hyperparathyroidism. Then after having discussed about the hyperparathyroidism, let me discuss about the hypoparathyroidism. So in case of hypoparathyroidism, as the word itself tells you, that there is decrease in parathormone. Now what are the various etiologies causing hypoparathyroidism is that acute form of the hypoparathyroidism, this is caused by the surgical resection of the parathyroid gland, right? So why is that you do surgical resection? When you are doing a surgical resection of a thyroid goiter, right? When you are doing a surgical resection of the thyroid goiter, then in such case the parathyroid glands are also taken off, and that will result in the hypoparathyroidism, and it is an acute form of hypoparathyroidism, right? Then what are the chronic causes for the hypoparathyroidism? That includes the hypomagnesemia, because magnesium is required for the release of parathormone from parathyroid gland. If there is hypomagnesemia, that will result in hypoparathyroidism, right? And we have a genetic disorder, and this particular genetic disorder is the 𝗑𝐬𝐬𝐷 syndrome, right? So this particular genetic disorder will be 𝗑𝐬𝐬𝐷 syndrome. It is the abnormality on chromosome number 22 that will result in the hypoparathyroidism, right? And the other important etiologies that will be causing hypoparathyroidism will be abnormality within the parathyroid gland itself, resulting in decrease in parathormone secretion, right? Then what will be the clinical features? The clinical features are mainly because of the hypocalcemia, because in hypoparathyroidism the calcium levels are reduced, and thereby these patients, they will develop the perioral and the periungual paresthesias, right? They will develop perioral and as well as the periungual paresthesias, and these patients will also have tetany. This particular tetany is observed mainly when the calcium levels are less than 7 grams percentage. That is the point when these patients will develop tetany. Then the other important clinical features because of the hypocalcemia is there will be growth retardation in children, right? And these patients will also develop in case of latent tetany, the two important signs that you need to know is, one is the Chopstick sign and the other one is the Trousers sign. So Chopstick sign is that where you tap the facial nerve or the angle of the mandible, that will cause the spasm of the muscle on the affected side. And you take the Trousers sign. The Trousers sign is that you inflate the BP cuff and try to maintain the BP cuff between systolic and diastolic blood pressure. Wait for a few minutes, there will be development of the carpopedal spasm, and that is what is called as the Trousers sign. And these patients, they will also have bony abnormalities, and these bony abnormalities include, number one, there will be development of the 𝗓𝐼𝐴 and there will be development of the 𝗓𝐼𝐴. So these are the two important bony abnormalities. That is all because of the hypocalcemia. And finally, what is the cause of death in patients with the hypoparathyroidism is the hypocalcemia will cause laryngospasm, right? Will cause laryngospasm. And it is because of the laryngospasm these individuals will die. So this is about the clinical features due to the hypocalcemia. Then coming to the workup, these patients, they will have the hypocalcemia. There will be increase in the phosphorus levels, right? And what will happen to the alkaline phosphatase levels? The alkaline phosphatase levels, that remains normal in patients with the hypoparathyroidism, right? And the next important is you need to check the parathormone levels, that will be reduced. And what will happen to the urine phosphate levels? The urine phosphorus levels will be reduced because parathormone is the one which will inhibit the phosphate reabsorption at the level of the tubules, and that will increase the urine phosphate. And when parathormone is not there, the urine phosphate levels will be reduced. Then how is that you will treat? In cases of acute hypoparathyroidism, you need to give intravenous calcium gluconate. Right, you need to give intravenous calcium gluconate in case of the acute hypoparathyroidism. Whereas in cases of the chronic hypoparathyroidism, you need to give oral calcium gluconate. Right, you need to give the oral calcium gluconate, and then you need to give the vitamin D supplementation. That is in case of chronic hypoparathyroidism. Then we have one more entity called pseudo-hypoparathyroidism. Now, what do you understand by this? The pseudo-hypoparathyroidism. Pseudo-hypoparathyroidism is that where these patients will have the receptor resistance, right? Parathormone receptor resistance will be there in case of the pseudo-hypoparathyroidism. But parathormone levels, they are present in the adequate quantities in case of the pseudo-hypoparathyroidism. Because the receptors are being resistant, right? Parathormone is not able to act on the receptors, and thereby these patients will have the hypocalcemia. So what is the treatment that you need to give in these patients? The treatment is that you need to give the calcium gluconate because these patients are having the hypocalcemia. And you need to remember the pseudo-hypoparathyroidism, it is mainly due to a mutation of the gene, that is GNAS gene mutation. And this particular GNAS gene mutation will result in what is called GS alpha subunit deficiency. Right, that will result in the GS alpha subunit deficiency. So that is about your pseudo-hypoparathyroidism. And the most common form of pseudo-hypoparathyroidism is pseudo-hypoparathyroidism type 1A. This pseudo-hypoparathyroidism type 1A, it is associated with a very important syndrome called as Albright hereditary osteodystrophy. Right, 1A, it is associated with what is called Albright hereditary osteodystrophy, right, where these patients will have exostosis, and they will have bony abnormalities, they will have short 4th and 5th metacarpal bones, right, and they will be also have defect in the sensation of smell and as well as hearing. So that is what is the feature that you will have in case of Albright hereditary osteodystrophy. So this is about the quick revision of parathyroid related disorders. So now let me just do a quick revision of the thyroid related disorders. So thyroid related disorders, mainly we have the hypo and as well as the hyperthyroidism. But first you need to be aware of what do you mean by this word primary and secondary thyroid related disorders. The word primary thyroid related disorders are those where the pathology is within the thyroid gland, whereas secondary thyroid related disorders are those where the pathology is in the anterior pituitary or within the hypothalamus, is what is your thyroid related disorders. And the quick revision on the synthesis of the thyroid hormone is that the iodide is the first one which is being trapped into the follicular cell. The first step is the iodide trapping, where the I minus which is present within the blood will enter into the follicular cell through sodium iodide symporter, and the I minus which has entered into the cell, that will undergo oxidation, where I minus it gets converted into I0 or I plus, which is nothing but the iodonium, right? Then after that there will be organification, where I0 or I plus that will combine with thyroglobulin to form monoiodotyrosine or the diiodotyrosine. Okay, then followed by that you have what is called the coupling. So coupling is that where monoiodotyrosine or diiodotyrosine will combine to form T3, or diiodotyrosine and diiodotyrosine combine to form T4. But majority of the thyroid hormone which is being formed in the follicular cell is T4, and that will undergo deiodinization in the presence of the enzyme 5-deiodinase, where T4 is converted into T3, right? Now, after having discussed about that, let me just tell you first about the important etiologies that will be causing the hypothyroidism, and what are the very important etiologies that will be causing the hyperthyroidism. The important etiologies, or the most common cause of the hypothyroidism, particularly in India, that will be Hashimoto's thyroiditis, right? Whereas globally, what is the most common cause? Globally, the most common cause will be the iodine deficiency. Then apart from, and what exactly is your Hashimoto's? It is an autoimmune disorder where the antibodies are formed against, right, where the antibodies are formed against the thyroid peroxidase. So it is anti-TPO antibodies, right? It is anti-TPO antibodies which are being formed within the Hashimoto's thyroiditis, right? Then you need to be aware that there are certain drugs which will be causing hypothyroidism, and that includes the amiodarone, right? And that includes the amiodarone, right? Now, apart from this amiodarone, the other drugs which will be causing the hypothyroidism will be para-aminosalicylic acid, lithium, then interferons, and we have an anti-neoplastic drug, that is the sunitinib. So these are the drugs that will be causing the hypothyroidism, and we have some infiltrative disorders that will be causing the hypothyroidism, which includes sarcoidosis, where there is accumulation of the non-caseating granuloma within the thyroid follicular cell. Next, hemochromatosis, where there is accumulation of excess amount of iron within the follicular cell. Then followed by that, the amyloidosis, where there is excessive accumulation of abnormal protein within the thyroid follicular cell. And you have abnormality related to the cysteine metabolism, right? That is the cystinosis, where there is excessive cysteine accumulation within the follicular cell causing hypothyroidism. Then we have the Riedl's thyroiditis. So Riedl's thyroiditis is that where there is fibrous tissue which is accumulated within the thyroid follicular cell, where the thyroid gland will be very hard in consistency. It is like stony hard that you have in case of the Riedl's thyroiditis. So these are all the etiologies that will be causing hypothyroidism. Then what is the most common cause of the hyperthyroidism? Most common cause of hyperthyroidism will be Graves'. And this is also an autoimmune disorder, right? So this is also an autoimmune disorder, right? And this particular Graves', which is an autoimmune disorder, what is the antibody? The important antibody is thyroid stimulating immunoglobulin. That is what you will observe in case of the hyperthyroidism. Then what are the other etiologies that will be causing hyperthyroidism is even certain drugs like amiodarone. So amiodarone, it can cause both hyper and as well as hypothyroidism as well. Now how is that it will cause hyperthyroidism is by thyroiditis, right? Amiodarone induced thyroiditis is the one which will result in the development of the hyperthyroidism. Then followed by that, the other etiologies that will be causing hyperthyroidism will be 𝗑𝐿 thyroiditis, right? That includes the 𝗑𝐿 thyroiditis. Okay, so 𝗑𝐼𝐼𝐻 thyroiditis is the one which occurs secondary to the upper respiratory tract infection secondary to virus. So it is viral induced thyroiditis. In case of 𝗑𝐼𝐻 thyroiditis, initially it will be hyper and later it will be hypothyroidism. And it is also called granulomatous thyroiditis because you have the formation of the granuloma within the thyroid gland, and the thyroid gland, it is very tender in consistency in case of 𝗑𝐼𝐻 thyroiditis. And 𝗑𝐼𝐻 thyroiditis is secondary to the inflammation. That is the reason why it is your painful thyroid, and if you do a ESR will be raised. And in patients with 𝗑𝐼𝐻 thyroiditis, when you do radioactive iodine uptake studies, there will be decreased radioactive iodine uptake studies in case of the 𝗑𝐼𝐻 thyroiditis, and ESR is also elevated. And because it's an inflammatory pathology, you need to give the anti-inflammatory drugs in patients with the 𝗑𝐼𝐻 thyroiditis, right? Then the other important etiology that will be causing hyperthyroidism is the HCG mediated hyperthyroidism, that includes hyperemesis gravidarum and as well as the trophoblastic diseases. Even that will be causing the hyperthyroidism, right? And the next one is the pituitary adenoma, that is thyrotroph type of pituitary adenoma is the one which will be causing the hyperthyroidism. So these are the etiologies that will be causing the hypo and as well as the hyperthyroidism. Now you need to know the clinical features about the hypo and hyperthyroidism. The clinical features that you will have in the hypo and the clinical features that you will have in the hyper, that includes the following. So first and foremost, related to the BMR. So thyroid hormone is the one which will increase the BMR of the individual. So in patients with the hypothyroidism, the BMR is reduced. Thereby these patients, they will have the cold intolerance, right? They will have the cold intolerance, okay, and they will have dry skin. And how will be the appetite in these individuals? They will be having decreased appetite, and there will be weight gain in these patients with the hypothyroidism. Whereas in hyperthyroidism, it is exactly reverse. These patients will have the heat intolerance because of excessive increase in the BMR, and there will be profuse sweating of the skin, and the appetite will be increased, right? And these patients, they will have the weight loss, okay? So that is about like what will be the features in the hyperthyroidism. Then you take related to the glucose metabolism. There is increase in hepatic gluconeogenesis by the thyroid hormone. So thereby in hyperthyroidism, there will be hyperglycemia, where the entire non-carbohydrate moieties are converted into glucose. Whereas in hypothyroidism, the glucose levels will remain normal. And related to the protein metabolism, there is excessive proteolysis, right? And because of the excessive proteolysis, in patients with hyperthyroidism, they will have the proximal muscle weakness, right? They will have the proximal muscle weakness. Whereas in case of the hypothyroidism, they will have muscle fatigue because the thyroid hormone is not there. So protein metabolism will not be there in these patients with the hypothyroidism. Then you take the fat metabolism. So there is excessive lipolysis which is caused by thyroid hormone. So in patients with hyperthyroidism, there is increase in the free fatty acid levels. So the cholesterol level and the triglyceride levels will be reduced, right? Decrease in cholesterol and decrease in triglycerides. So in patients with hypothyroidism, the lipid metabolism does not occur. There will be excess increase in cholesterol and excess increase in triglycerides and excess increase in the LDL and excess increase in the VLDL. So these patients will develop what is called as the dyslipidemias, right? These patients will develop what is called dyslipidemias that will make the individual to develop the coronary artery disease. So that is about the fat metabolism. Then what will happen to the cardiovascular system in patients with hypothyroidism is they will develop diastolic hypertension, they will have pericardial effusion, they will have first degree AV block, right? And they will be having severe bradycardia in patients with hypothyroidism. Whereas you take in hyperthyroidism, they will have tachycardia, they will have arrhythmias, right? And all the types of arrhythmias are observed, but atrial fibrillation is common, and because of which there is irregular pulse, right? So because of which there is irregular pulse, okay? And the next important point here is in patients with the hyperthyroidism, they will have palpitations because of the arrhythmias, right? So they will have palpitations because of the arrhythmias, and these patients, they go into a state of the high output heart failure, right? They go into a state of high output heart failure. Then followed by that, in patients with hyperthyroidism, they will have a systolic murmur, and the name of this systolic murmur is a Means-Lerman scratch, right? And it is a mid-systolic murmur, okay, or it is also nothing but ejection systolic murmur. That is what you will have in case of the hyperthyroidism. Then you take the respiratory system. In hypothyroidism, they will have a type 2 respiratory failure, where these patients will have hypoxia and as well as the hypercapnia. Whereas in hyperthyroidism, there is increase in the respiratory rate. They will have tachypnea. Whereas GI manifestations, if you observe in hypothyroidism, these patients, they will develop constipation, whereas in hyperthyroidism, they will have diarrhea, right? They'll have diarrhea, okay? And next important is CNS manifestations. In hypothyroidism, the patient will be dull and lethargic, whereas in patients with the hyperthyroidism, they will be having tremors, increased tremors that you will be able to elicit when the patient outstretches the hand. And the other important feature, CNS manifestation, is the anxiety, and there is extreme nervousness, right? There is extreme nervousness, right? And the other important CNS manifestation is there will be brisk deep tendon reflexes, whereas in hypothyroidism, there is delayed relaxation of deep tendon reflexes, and that we call it as the hung up reflex. And this particular hung up reflex, it is the most reliable sign for the diagnosis of the hypothyroidism. And this hung up reflex is mainly elicited over the ankle, that is nothing but the ankle jerk. And how will be the skin of these individuals in case of the hypothyroidism? There will be yellow skin. Why is that yellow skin? That is because of the beta carotenemia. So beta carotene has to get converted into vitamin A in the presence of thyroid hormone. When thyroid hormone is not there, the beta carotene is not converted into vitamin A. Increase in the levels of beta carotene, that will give yellowishness to the skin. And how is that you will be able to differentiate this from the jaundice? In jaundice, there will be yellow eyes, but in beta carotenemia, the eyes will be normal. Whereas in case of hyperthyroidism, the skin, you will have what is called a pretibial myxedema, which is nothing but the waxy skin, right? Which is nothing but the waxy skin over the shin of the tibia. And how will be the sleep of these individuals? In hypothyroidism, they'll have excessive sleep, whereas in hyperthyroidism, there is decreased or disturbed sleep because of the anxiety and extreme nervousness. And the next very important is, you need to be aware of like ophthalmopathy. So ophthalmopathy features are not observed in case of hypothyroidism, but you will have what is called Graves' ophthalmopathy in case of the hyperthyroidism, where there will be protrusion of the eyeball, and there is also lid lag, and that is due to contraction of the Muller's muscle, right? And next is the clubbing. So if you take this clubbing is absent in case of the hypothyroidism but present in case of the hyperthyroidism, and that we call it as the thyroid acropathy, where you have the presence of clubbing, right? The next important finding that you need to be aware is, there are two important findings, that is, or two important terminologies. So in individual with endemic iodine deficiency goiter, right, in individual with endemic iodine deficiency goiter, when you give the exogenous iodine, right, when you give the exogenous iodine, the individual will develop either hyperthyroidism or the individual will develop the hypothyroidism, okay? So iodine induced hyperthyroidism, right, iodine induced hyperthyroidism is what is called as the Jod-Bezos phenomena, whereas iodine induced hypothyroidism is what is nothing but the 𝐒𝐿𝐵-Chaikov effect. Now what is the reason for this 𝐒𝐿𝐵-Chaikov effect? That is because of transient inhibition of organification in patients with the 𝐒𝐿𝐵-Chaikov effect. Then how is that you will do the workup in these patients? So you need to work up based on the thyroid profile, that is T3, T4, TSH. And you should know like what will be the thyroid profile in primary hypothyroidism, secondary hypothyroidism, then in primary hyperthyroidism, and in case of secondary hyperthyroidism. So primary means the pathology is in the gland, secondary means the pathology is in anterior pituitary. In primary hypo, T3, T4 will be reduced and TSH will be increased, whereas in secondary hypo, everything will be decreased. Whereas in primary hyper, T3, T4 will be increased, the TSH will be reduced, whereas in secondary hyper, everything will be increased in case of the secondary hyper, right? This will be the thyroid profile. Now out of which is very important is the TSH. Very important is TSH. And the next important you need to know is about the radioactive iodine uptake studies. So radioactive iodine uptake studies, we do that with the help of the iodine 132 or iodine 123. So iodine 132 or iodine 123, what are the conditions where there is increased uptake of radioactive iodine is, that is in case of the Graves' disease. In Graves' disease, there is increased radioactive iodine uptake, right? And in patients with thyroiditis, there is increased radioactive iodine uptake. So these are the conditions where there is increased. And the conditions where there is decreased radioactive iodine uptake is, that is in patients with 𝗑𝐿 thyroiditis. Right? And what type of thyroid here? That should be thyroid adenoma or the thyroid tumor. There will be increased radioactive iodine uptake. Whereas in 𝗑𝐿 thyroiditis, there is decreased radioactive iodine uptake. And what exactly is 𝗑𝐿? I said you. Then coming to the two extreme forms of thyroid. The two extreme forms of thyroid is myxedema coma, and the next important is the thyroid storm. So myxedema coma is that where there is abrupt and severe decrease in T3, T4, whereas thyroid storm is that where there is abrupt and severe increase in T3 and as well as T4. That is what is your thyroid storm. So you take in case of myxedema coma, what is the drug of choice? The drug of choice is the intravenous T4, whereas in thyroid storm, the drug of choice is the nasogastric propylthiouracil in case of the thyroid storm, right? So this is what is the difference between myxedema coma and thyroid storm. And in myxedema coma, the individual will go into a state of altered sensorium and as well as coma, and that is mainly because of the hyponatremia, right? Then how is that you will do a treatment for hypo and as well as hyperthyroidism? So you take in patients with the hypothyroidism, right? I'm not talking about myxedema coma. In general, hypothyroidism. So patients with hypothyroidism, the drug of choice is levothyroxine. And this particular levothyroxine, it has to be administered early in the morning fasting state. And the dosage will be 1.6 micrograms per kg body weight. But whenever you are starting levothyroxine, you need to check the cardiac status. If the individual is having underlying coronary artery disease, you need to start with low dose and step up. But if the patient is not having any cardiac disorders, then you can give a full dose of 1.6 micrograms per kg per body weight, right? Then you take in case of the hyperthyroidism. In hyperthyroidism, what are all the various options of the drugs that we need to give is, you need to give beta blockers, that is propranolol. And what is the purpose of giving the propranolol? The propranolol we give because it will reduce the heart rate, it will reduce the anxiety, it will reduce the tremors. And you also need to give anti-thyroid drugs. The anti-thyroid drugs that we give in patients with the hyperthyroidism will be, drug of choice will be methimazole. But this particular methimazole, you cannot give that in the first trimester of pregnancy because methimazole is associated with teratogenic adverse effect, that is aplasia cutis. So that is the reason why in the first trimester, the drug of choice will be the propylthiouracil. Whereas in second and third trimester, we again shift back to methimazole. But why is it you are not continuing propylthiouracil in second and third trimester is because propylthiouracil, it has a short half-life, and second important point, the propylthiouracil, it is associated with liver fibrosis or hepatic abnormality. That is the reason why in second and third trimester we just confine to give methimazole because it has a long half-life and it does not cause a hepatic fibrosis. Then the radioiodine substance, radioactive iodine that can be given as a part of the treatment is the iodine 131, and the next important is surgical resection of if there is presence of a large goiter causing mass effect like dysphagia, dyspnea and hoarseness of voice, then you need to do the surgical resection of the thyroid gland. So this is about the treatment of thyroid related disorders and quick recap of the entire thyroid. So now let me just do a quick revision of the diabetes mellitus. So diabetes mellitus is the disorder which is characterized by the hyperglycemia. So we have the following forms of the diabetes mellitus. That includes the type 1 diabetes mellitus, then type 2 diabetes mellitus. Then we have the variants of diabetes mellitus, which includes maturity onset diabetes of young and then latent autoimmune diabetes of adults, that is LADA, right? Then we also have some drugs which will be causing hyperglycemia, and we also have the endocrine disorders which will be causing the hyperglycemia, right? Then we have GDM, that is gestational diabetes mellitus. Now, if you take the differences between the type 1 and as well as the type 2 diabetes mellitus, so in type 1 diabetes mellitus, the age of presentation is less than 30 years. The age of presentation is less than 20 years in case of type 1 diabetes mellitus, whereas in type 2 diabetes mellitus, the age of presentation is more than 30 years. And if you take the BMI of these individuals, type 1 diabetes mellitus, they have normal BMI, whereas type 2 diabetes mellitus, these individuals, they are obese or there will be increased BMI in type 2 diabetes mellitus. And the next important is about the HLA association. In type 1, you have HLA-DR3 and as well as HLA-DR4 association. But whereas in type 2 diabetes mellitus, there is no HLA association, right? Now, another very important point about the type 1 diabetes mellitus and is, in case of type 1, it is the beta cell destruction that is because of the antibody. So antibody mediated beta cell destruction. Whereas in case of type 2 diabetes mellitus, the beta cells will be normal in early stages, right? So it will be normal in early stages, but in the later stages, the number of the beta cells will be reduced. So accordingly, if you take the insulin, so insulin in case of type 1, it is reduced, whereas in type 2, the insulin levels, in fact, they will be increased because of increased activity of the beta cells, right? But later stages when the beta cells are reduced, then the insulin level will be reduced. Then what are the etiologies that will be causing etiology and as well as the risk factor? In case of type 1 diabetes mellitus, like it is mainly the antibody. The antibodies are the anti-GAD antibodies, right, and as well as the islet cell antibodies. These are the antibodies that will be destroying the beta cells. Then the next important is we have what is called the fulminant diabetes mellitus. Now what do you understand by this word fulminant diabetes mellitus is, it is secondary to viral infection, mainly the Coxsackie virus, right? It is mainly secondary to the Coxsackie virus. Now this particular Coxsackie virus will induce the immune system to produce antibodies. Antibodies are formed against the Coxsackie virus, and the same antibodies, they will destroy the beta cells, and thereby the beta cells will be reduced and insulin level also will be reduced. Then we have next important form of diabetes mellitus called bronze diabetes mellitus. Bronze diabetes mellitus is observed in case of hemochromatosis, where there will be like cirrhosis of liver, type 1 diabetes mellitus and bronzing of the skin. That is what is your bronze diabetes mellitus. Whereas type 2 diabetes mellitus, the important pathogenesis is insulin resistance. Now, what is the risk factor for the development of the insulin resistance? That is obesity. And that too, central obesity or abdominal fat, that is the important risk factor for the development of type 2 diabetes mellitus. And the other important risk factors for the development of type 2 diabetes mellitus is vitamin D deficiency, then cigarette smoking, right? Then sedentary lifestyle, right? Sedentary lifestyle. So these are the risk factors for the development of the type 2 diabetes mellitus, right? Then you take the clinical features. In patients with type 1, you have this classical clinical features like polyuria, polydipsia and as well as the polyphagia. Whereas in type 2 diabetes mellitus, this polyuria, polydipsia, polyphagia, they are uncommon, but these individuals with type 2, they are at increased risk of infections, right? These patients with type 2, they will have a poor wound healing, right? They will have a poor wound healing, okay? And there is excessive fatigability in patients with the type 2 diabetes mellitus. And if you take the acute complications in type 1 diabetes mellitus, these patients, they are at increased risk of development of diabetic ketoacidosis. Diabetic ketoacidosis is observed in both type 1 and as well as type 2, but it is more common in type 1 rather than type 2. And another important is the hyperosmolar non-ketotic coma, where the ketone bodies will be negative in patients with the 𝐿, and this 𝐿, it is more common in type 2 rather than the type 1 diabetes mellitus, right? Then how is that you will treat these patients? Type 1 diabetes mellitus, definitely you will be requiring the insulin, whereas type 2 diabetes mellitus, the oral hypoglycemic agents is what we need to give. But what will be the first line treatment? Either you take in type 1 or type 2, the first line treatment will be the lifestyle modification, right? Then followed by that, in the OHA of your type 2 diabetes mellitus, what exactly is the drug of choice? The drug of choice will be metformin. Okay, so this is about, these are some of the differences between type 1 and as well as type 2. And a very important complication is the dyslipidemia. So the dyslipidemias, they are more common in type 2 rather than type 1. And the most common form of dyslipidemia is the hypertriglyceridemia. Then followed by that, the cholesterol levels will be increased and the LDL level will be increased, VLDL level will be increased, and HDL level will be decreased. So this will be the dyslipidemia in case of type 2 diabetes mellitus, but the most common will be the hypertriglyceridemia, right? So these are some of the differences between type 1 and type 2. Then you take the variants, okay, and next is you need to know the drugs that will be causing hyperglycemia. The drugs that will be causing hyperglycemia, that includes steroids, then we have thiazide group of diuretics, then we have a rodenticide, accidental poisoning, that is accidental poisoning with rodenticide, that is 𝗑𝐽𝑟, right? 𝗑𝐽𝑟 is a rodenticide, right? And then protease inhibitors, which are used in the treatment of the retroviral infection, then beta 2 agonists, right, or the beta agonists. These are the drugs that will be causing hyperglycemia. And there are certain endocrine disorders that will be causing hyperglycemia, and these endocrine disorders causing hyperglycemia, that includes the acromegaly, then the Cushing syndrome, then thyrotoxicosis, then pheochromocytoma, then glucagonoma. So these are the etiologies that will be causing the hyperglycemia, right? Now we will discuss the variants of diabetes mellitus, that is the MODY, that is maturity onset diabetes of young. Maturity onset diabetes of young, right, the age group at which you will see this MODY is in between 20 to 30 years of age. And the important pathogenesis here is the beta cell dysfunction, right? The important pathogenesis is beta cell dysfunction. That is what you will observe in case of maturity onset diabetes of young. And this particular MODY, where there is beta cell dysfunction, that is mainly because of the gene mutation, right? And this MODY, we have the various forms, right? We have MODY 1 to 6. So out of which you take MODY 3. MODY 3, that is the most common form of the MODY, right? The MODY 3, it is the most common form of MODY. And in case of the MODY 3, what is the gene that is being mutated? The gene that is being mutated is the HNF1 alpha. That is the most common gene that is being mutated, or the most common form of MODY. The gene mutated is HNF1 alpha, and that will result in the beta cell dysfunction. And because of the beta cell dysfunction, what will happen to the insulin levels? They are reduced. So it is not beta cell destruction here, it is only beta cell dysfunction. And these patients, they will have normal BMI, and they never develop this diabetic ketoacidosis, and they have very strong genetic inheritance. Minimum 2 generations are diabetic, right? Minimum 2 generations are diabetic. It is not only the father, even grandfather also should be diabetic to call it as the MODY, that is maturity onset diabetes of young. Now what is the treatment that you will be giving in case of the MODY is that the drug of choice is you need to give a low dose sulfonylurea, right? You need to give a low dose sulfonylurea, and that low dose sulfonylurea that we give is glimepiride, which will stimulate the beta cells to produce the insulin. Okay, so that is about the MODY, maturity onset diabetes of young. Then you take LADA. So LADA, it stands for latent autoimmune diabetes of adults. Latent autoimmune diabetes of adults. This is also called as the type 1.5 diabetes mellitus, and this is one of the rare form of diabetes mellitus. So here you have the formation of the antibodies, and these antibodies are the anti-GAD antibodies and then the islet cell antibodies. These antibodies, they destroy the beta cells, thereby what will happen to the insulin level? There will be decrease in the insulin level, right? So what is the treatment that we'll be giving in LADA is, the treatment is we need to give insulin because these patients, the insulin levels are reduced, and it is usually observed in adults. Right, it is usually observed in adults. So this is what is called as LADA, that is latent autoimmune diabetes of adults. Then followed by that, you need to know how to diagnose this diabetes mellitus. Diagnosis of diabetes mellitus is based on fasting blood sugar, postprandial blood sugar, and then the HbA1c. So you should know normal value, when do you call it as impaired values, and when do you call a value of diabetic range, and what should be the target value, right? So the normal value of your FBS is, it should be less than 100, PPBS should be less than 140, HbA1c should be less than 5.6. The impaired value, FBS, it is 101 to 125 milligrams per deciliter, PPBS 141 to 199 milligrams per deciliter, HbA1c 5.7 to 6.4. Okay, these are the impaired values. Diabetic range will be FBS more than or equal to 126, PPBS more than or equal to 200, and HbA1c more than or equal to 6.5. And what will be the target values? So if you see the target value of the FBS, that should be less than 130. What do you mean by the word target value? That means in already known diabetic, how much should be the values? Okay, so FBS should be less than 130, PPBS should be less than 180 milligrams per deciliter, and HbA1c should be less than 7%. And based on random blood sugar also, we will be able to assess the diabetes mellitus. Random blood sugars, if the values are more than 200, along with that the clinical features of diabetes mellitus are there, then also we can diagnose that the patient is having diabetes mellitus. And your HbA1c, if you take, this will tell you the blood glucose levels of the past 3 months. And the very important contraindication for HbA1c is that in anemia, you should not do the levels of the HbA1c. It will give you a false low values. And in order to have a quick blood glucose control of past 2 to 3 months, then we do what is called as the serum fructosamine. So serum fructosamine, this will give you the blood glucose value of, the blood glucose control of past 2 to 3 weeks, right? Past 2 to 3 weeks. And very important point about the serum fructosamine is that the serum fructosamine, it is contraindicated in conditions like nephrotic syndrome, right? And it is also avoided in cirrhosis of liver. So in nephrotic syndrome and as well as cirrhosis of liver, the serum fructosamine levels should not be done, right? Then followed by that, you need to know the complications in diabetes mellitus. So I have already discussed the acute complications, but if you take the chronic complications in diabetes mellitus, the chronic complications, we classify them into, right? We classify them into the microvascular complications and then macrovascular complications. Microvascular complications include diabetic neuropathy, right? Then diabetic nephropathy, right? Then diabetic retinopathy. So these are the microvascular complications that you will have in patients with the diabetes mellitus. Whereas macrovascular complications include the coronary artery disease, cerebrovascular accidents, and then the peripheral arterial disease. So these are the macrovascular complications that you will have in patients with the diabetes mellitus, right? Now, quick discussion related to the diabetic ketoacidosis is that diabetic ketoacidosis, it is characterized by a triad, and this particular triad include the blood glucose value more than 250 milligrams per deciliter. The ketone bodies will be positive, right? And in these individuals, there will be acidotic pH, right? And the clinical presentation in these patients will be in the form of the dyspnea, and they will also have the abdominal pain, and on examination, they have a characteristic respiratory pattern that is called as the Kussmaul's respiration. That is what you will observe in diabetic ketoacidosis. And in diabetic ketoacidosis, what is the first line treatment? The first line treatment is IV fluids, that is normal saline is what you need to give. And then followed by that, you need to give IV insulin infusion, and the type of insulin that we give here is the regular insulin is what we give. Regular insulin infusion has to be given. But when you are giving this regular insulin infusion, that will result in hypokalemia. So you need to monitor for the potassium levels, right? And if the pH is less than 7, you also need to give intravenous sodium bicarbonate. And one of the very important precipitating factor for the development of diabetic ketoacidosis is infection. So you need to give a broad spectrum antibiotics like ceftriaxone has to be given, right? Intravenous route. So that is about your diabetic ketoacidosis. Now, how is it different in HONC? In hyperosmolar non-ketotic coma, which is more common in type 2 rather than type 1, here the ketone bodies are absent. But if you take the blood glucose levels, they are in a range of 600 to 1200 milligrams per deciliter, and the serum osmolarity is grossly increased, and thereby these patients will have CNS manifestations in the form of the confusion and as well as the seizures. And these patients with hyperosmolar non-ketotic coma, the treatment is same. You need to give IV fluids, that is normal saline, and then you need to give IV infusion of regular insulin, right? IV infusion of regular insulin. Whereas in HONC, the pH is normal. It is not the acidotic pH. So this is about the hyperosmolar non-ketotic coma, right? And some of the important complications related to the insulin. Some of the important complications related to the insulin is the development of early morning hyperglycemia, right? Development of early morning hyperglycemia. Now, what are the causes for early morning hyperglycemia is, number one, the fasting hyperglycemia, right? Then we have Donn's phenomena, right? Then we have 𝐒𝐮𝐫𝐞 phenomena. So these are the conditions where you will have the early morning hyperglycemia. Fasting hyperglycemia is because of inadequate administration of night dose of insulin. The patient was advised 20 units, but the patient has taken only 10 units in the night. So thereby, all through the night, the blood glucose levels will not be controlled. So if you check the 3 AM blood glucose levels will be high, and even 6 AM blood glucose levels also will be high because the patient did not take adequate dose of the insulin. And Donn's phenomena, it is due to early morning growth hormone surge. That is, at 6 AM growth hormone surge is what is responsible for early morning hyperglycemia. So in Donn's phenomena patients, 3 AM blood glucose levels will be normal, but 6 AM blood glucose levels will be high. Whereas 𝐒𝐮𝐫𝐞, that is due to excess night dose of insulin. Patient was advised to take 10 units, but the patient has taken 20 units accidentally or by mistake. What will happen? So in the midnight, the blood glucose levels drop down because the patient has taken excess dose. And because of hypoglycemia, there will be release of counter-regulatory hormones like glucagon, steroids, thyroid, and as well as catecholamines. Growth hormone will increase the 6 AM blood glucose levels. Okay. So in fasting hyperglycemia, 3 AM, 6 AM increased. In Donn's phenomena, 3 AM normal, 6 AM increased. Whereas in 𝐒𝐮𝐫𝐞, 3 AM reduced and 6 AM blood glucose levels are increased. So this is about the causes for early morning hyperglycemia. So this is in short about revision related to diabetes mellitus and the entire endocrinology. Thank you very much.